Hello, my name is Rochelle Fontilla, and this is my son Dennis. He is 15, but I am consenting for this video to be recorded to be turned into Touro University. So today I am going to be doing your head-to-toe assessment. I am going to be your nurse practitioner, and I will be doing all of these assessments. At any time, if you feel any tenderness or pain, you just let me know and we will stop, okay?
Okay.
Okay. I am going to do my hand hygiene. Okay, tell me your name.
Dennis Fontilla Jr.
Okay. And Dennis, how old are you?
15.
Perfect. And do you know where you are?
I'm at my house.
What city are we in?
Las Vegas.
Do you know the day of the week?
Sunday.
Okay. And do you know what month are we on?
October.
Okay, perfect. So I will be doing the general survey. This is a 15-year-old male. He is healthy appearing. He is well-developed male. He is alert and oriented to person, place, and time. He is pleasant. He is responsive to questions. He is Asian, so his skin color is consistent with his genetic background. He is dressed appropriately for the situation, and he is sitting upright, and he is relaxed and not in any apparent distress. Okay, so now we are going to begin with cranial nerve assessment. So the first one is the cranial nerve 1, which is the olfactory. Olfactory is a sensory nerve, and this will check for the patency of your nostrils. So first I'm going to have you occlude one nostril for me, and you're going to inhale. It's patent and it has good airflow, and then the other one as well. Perfect. So bilateral nostrils are patent and has good airflow. I am going to mark my paper here just so I know where I'm at. This is my guide. Okay. And then the next one I'm going to have you do is I'm going to have you identify the scent for me. Okay. So I'm going to have you close your eyes, and then you're going to occlude one nostril for me, and you just tell me as soon as you smell it.
Mint.
Oh, perfect. And then you're going to close your eyes again and then occlude the other one. Okay.
Coffee.
Okay, perfect. So Dennis, okay, that's good. Dennis was able to identify differentiate between the mint and the coffee scent. Cranial nerve 1 olfactory is intact. The next cranial nerve that I'm going to be checking is the cranial nerve number 2, which is the optic nerve. First, I am going to assess for his vision by using my Snellen chart. Dennis, do you wear glasses?
No.
Okay. I'm going to use my Snellen chart here. So first, you're going to read the smallest letter that you can, okay?
Okay. LTFPH.
Actually, no, I did this the wrong way. I'm going to have you cover one eye for me. Okay, and then I'm going to back up a little bit, and then you're going to read this.
LTFPH.
Perfect. For the right eye, Dennis was able to read the 20/20 vision without any correction. And then I'm going to have you cover the other side, and then read again the smallest letter.
LTFPH.
Okay, perfect. So for the left eye, Dennis was able to read the 20/20 as well without any correction. The next one that I'm going to have, the next one that I'm going to be assessing is the visual fields. I'm going to be using the confrontation test. So for this one, you're just going to tell me how many numbers I'm holding up, okay? So I'm going to have you cover one eye for me, and you're just going to tell me how many numbers I'm holding up, okay?
2, 1, 2, 3.
Okay, perfect. So on the right eye, your visual field is intact, and then we're going to do it on the left.
1, 2, 2, 2.
Okay, perfect. So on the left one, your visual field is intact. I did not see any defects or uh, visual field is intact. There's no defect. I did not see any defect on that. The next one I'm going to be doing is the fundoscopic exam. I'm going to be using the ophthalmoscope. So this one is a bright light. I'm going to be looking behind your eye, okay? So first I am going to be starting far away and then I go closer to you, okay? I'm just going to have you look straight for me.
Okay.
Higher a little bit. Let's just look straight up. Okay. 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 And then I'm going to do it on the other side as well. Right on right. I'm going to cover my eye over here. Start forward. And I'm going to just look straight for me, okay? Okay. So for that one, the red reflex was visible. Red reflex was visible. The optic disc is clear. It's round, creamy pink. Margins are sharp. Central area of the cup was pale, and then the disc ratio is less than half. There's no swelling noted. No increased cupping noted as well. And then for the retinal background, it was reddish orange in color. Macula is slightly dark. And then for the vessels, the arteries appear bright red. The veins are slightly purple. Artery to vein ratio is about 2 to 3, with veins larger than arteries. There's no tortuosity of vessel visible and no exudate or hemorrhages noted. Okay, so the next one that I'm going to be doing is the cranial nerve 3, 4, and 6. So these are all motor nerves, which assesses for the muscles of the eyes. The cranial nerve 3 is oculomotor, and this one checks for the pupillary constriction, and then the levator muscle, and then also the muscles of the eye in the superior, the medial, and inferior rectus, and then also the inferior oblique muscle. And then for cranial nerve 4, this is trochlear. It is checking for medial eye movement by superior oblique muscle. And then cranial nerve 6 is abducens. This is the lateral eye movement by lateral rectus muscle. Okay, so first I will be checking for your pupils. This is the cranial nerve 3. I'm going to shine a light on your eye. Okay, perfect. So I'm going to shine a light on your eye, and what I'm looking for is the direct response and then the consensual response from on the opposite side. Okay, so I'm going to have you just look straight for me. First, I'm going to do it on the right side. Okay, so direct response is intact on the right eye, and now I'm looking for the consensual response on the opposite eye, and that is intact. And then this one again on the left is the direct response is intact, and then the consensual response on the opposite eye is intact. The next one that I'm going to be doing is your pupil diameter is about 5 millimeter. Both pupils are equal, round, and they are reactive to light. Now I'm going to be testing for accommodation, so I'm just going to have you look straight ahead for me, and then I'm going to check for your accommodation, okay? So just look straight for me. Now look at my finger. Okay, so both eyes accommodation are intact. So the patient has pupils, bilateral eyes. Pupils are equal, reactive, round. I'm sorry, pupils are equal, round, reactive to light, and accommodations are intact. Okay, now I'm going to be checking for um, cardinal fields of uh, cardinal fields of gaze, which is the your extraocular movement of your eyes. So I'm just gonna have you follow my finger with just your eye, okay? Okay, perfect. Um, I did not see any paralysis or of the eye muscle or any nystagmus. Now I am going to be, your extraocular movement is intact. It is smooth. And then now I'm going to be performing the corneal light reflex. So I'm going to shine the light on your nose, on the bridge of your nose. I'm sorry. Okay. I'm going to shine the light on the bridge of your nose. Okay, perfect. I see that both eyes remain aligned. There's no ocular. I see that the symmetric light reflex with corneal light reflex test. And then the next one I'm going to be checking is the cover uncover test. And I'm going to be using this one. Let's turn off this light. Okay, so for this one, I'm just gonna do a cover and uncover test. So I'm gonna cover one eye and then uncover it, okay? So cover and uncover. You're just gonna look straight for me, okay? Okay, perfect. Both eyes remain aligned. There's no ocular deviation noted. The next one that I'm going to be checking is trigeminal nerve. For this one, this is a mix of both motor and sensory. I am going to be testing the lateral jaw movement. So I'm gonna have you grit your teeth while I'm palpating, okay? Okay, perfect. And then grit your teeth for me. Okay, perfect. So for that test, there are no limitations in muscle of mastication. When I palpated the temporal and masseter muscle, it was nice and strong response. Now I'm going to be checking for the sensory part of the trigeminal nerve. I will test the sensation of your eyebrow, cheeks, and chin by using the Q-tip. Okay, so now you're just going to close your eyes and you're going to tell me if it's sharp or dull.
Okay.
So this is sharp, this is dull. Okay, close your eyes for me.
Dull. Sharp. Sharp. Dull. Sharp. Dull.
Okay, perfect. So for that one, your sensation on 3 distribution of trigeminal nerves are intact. The next one that I'm going to be checking is cranial nerve number 7. This is a mix of both motor and sensory function as well. So I am going to, for the sensory part of this, we are going to skip it, but it is the 2/3 anterior of the tongue. It is a taste test. It's a test of taste, but we're not going to do that for the sake of this video. So for the motor part, I'm gonna have you move some facial muscle for me, okay? Raise your eyebrows for me, puff out your cheeks, give me a big smile, and show me your teeth. Okay, perfect. Cranial nerve 7 is intact with symmetric movement bilaterally. The next one that I'm going to be checking is the acoustic nerve. I'm going to be first doing the whisper test. So for the whisper test, you're just going to repeat after me while you're covering the other ear, okay? So cover this ear for me.
Yellow. January. Happy.
Okay. Cover the other ear for me. And I'm going to be whispering here.
February. Green. Dog.
Okay, perfect. So the whisper test is bilaterally good hearing and it is intact. And the next one that I'm going to be doing is the Weber test. So I will be activating my tuning fork and I'm going to put it on top of your head. And all you need to tell me is if you hear it on both ears equally or just one. Okay? Both ears?
Both ears.
Equally?
Yes.
Okay, perfect. There's no lateralization of sound. If there is any lateralization on the affected ear, that would be conductive hearing loss. If the sound had lateralized on the non-affected ear, then that would be sensory neural hearing loss. The next one that I'm going to be checking for is the Rhine test. So again, I am going to activate the tuning fork and then put it on the back of your ear. You will tell me when you stop hearing it, and then I will put it in the front of your ear, okay? Okay.
Now. Now.
Okay, that's too fast.
Bring it harder.
Okay. Look straight for me.
Now. Now.
Okay, then we're going to do the other side as well.
Now. Now.
Okay. So for the Rhine test, AC is greater than BC with a 2-to-1 ratio, which is normal response. There is no conductive or sensory neural hearing loss. The next one that I'm going to be checking is the glossopharyngeal nerve. This is the cranial nerve 9 and then the cranial nerve 10, which is the vagus nerve. They are assessed together. They are mixed of motor and sensory. So cranial nerve 9, again, we're not going to do the taste part, but it's the posterior 1/3 of the tongue and the throat. So for the motor part of the cranial number 10, I'm going to have you, it checks for the muscles of larynx and pharynx, swallowing and phonation. So I am going to have you open your mouth and you are going to say ah, and then I'm going to look on there and I'm going to use my light and the tongue depressor. Oops. Okay. Okay. Take out your tongue for me. Okay, I'm gonna look in the back. Okay, uvula is medial. There is no deviation. It is nice and pink. There is no swelling on there. It was midline, symmetrical, and there's no deviation. And one more time for me, open. And gag reflex is intact. Okay, I'm sorry. Let's throw this in the trash. Cranial nerve 9 and cranial nerve 10 are intact. The next cranial nerve that I'm going to be checking for is cranial nerve 11, this is the spinal accessory nerve, and this is a motor nerve. It assesses for the strength of the spinal accessory nerve. So it mediates for trapezius and sternocleidomastoid. So I'm going to have you shrug your shoulder for me, shrug it up, and you're going to fight against resistance. Okay, so that one is intact. He was able to fight against the full resistance. And then I'm gonna have, I'm going to place my cheek for, place my hand on your cheek, and you're going to fight against resistance. Okay, and on the other two. Okay, perfect. So cranial nerve 11 is intact. He was able to push against full resistance. The next one that I'm going to be checking for is the hypoglossal. This is the cranial nerve number 12. This is the motor nerve, and it assesses for the movement of the tongue. So I'm going to have you stick your tongue out for me. Perfect. And the tongue is midline. There's no tremor or deviation noted. And then I'm going to have you swallow for me. Perfect. Cranial nerve 12 is intact. So now we are going to move to head and face assessment. So here, his hair is soft, it's evenly distributed, there's no signs of alopecia, his scalp is normocephalic, there's no masses, lesions, tenderness, or drainage noted, and then his facial features are symmetric, his skin is smooth, it's pink and warm, there's no redness or swelling noted. The next one that I'm going to be palpating for is for frontal sinuses, and you're just going to tell me if it hurts, okay? Does it hurt?
No.
Okay, now I'm going to be palpating for maxillary sinuses. Any pain at all?
No.
Okay, perfect. The next one I'm going to be inspecting for the eye. His eyes structure is his eye structures are symmetric. There's no ptosis noted. There's no drainage, crusting lesions, or edema noted on the eyelids or the lashes. Sclera is ecteric. Sclera is non-ecteric, and I'm going to pull down eyelid. Okay, perfect. The eyelids, both bilateral, is pink. The conjunctiva is pink, it's moist, there is no discharge noted. The cornea is clear and without opacities, and the iris is flat. So now I'm going to do the ears assessment. So first I am going to, you want to move here a little bit so I could reach you. Okay, so on both ears, I am observing here. I see that ears are in alignment with the outer canthus of eyes. I'm going to palpate for your auricle here. Is there any tenderness?
No.
Okay. On both auricles, there's no tenderness, no redness, no swelling, no discharge, or any skin tag noted. And then for the mastoid process over here, tell me if you feel any pain at all. Okay.
No.
Perfect. There's no tenderness or masses noted on bilateral mastoid process. I'm going to do the pull and back. So am I causing you pain by doing this?
No.
No?
No.
Okay, so if it's painful, then there is a sign of otitis externa, which is an ear infection. But for this patient, there is no tenderness or pain noted. Now I'm going to check for the inside the ears using my light. Okay, so now I am going to be checking for the extra auditory canal, I am going to be holding my otoscope with 3 fingers and rest the pinky on his cheek. So I'm going to have you tilt a little bit for me. Okay. Extra auditory canal is pink. There's no excess cerumen, no lesions, no ulcerations noted. And then the tympanic membrane is pearly gray, no neutral, no bulging, no erythema. Um, there is um, there is no effusion. On the left of light is cone of light is at 7 o'clock. The handle and short process of malleolus is visible. Okay, now we're gonna go on the other side. Okay, and I am gonna be doing the same thing again. Okay. So for the right ear, it's the same. External auditory canal was pink. There's no excess cerumen. There's no lesions or ulcerations noted. Tympanic membrane was pearly gray. Neutral, no bulging, no erythema, no effusion. And then the right cone of light was at 5 o'clock. Um, and the handle and short process of malleolus is visible. The next one I'm going to be checking is the throat. So I'm going to be checking for the lips. There is no ulcerations, no lesions, cracking, or dryness. I am going to inspect with light and tongue depressor. And you're going to open for me. Okay. I see that mucous membrane are pink on bilateral buccal. There is no swelling, no redness, no ulceration, no nodules. And then close your mouth for me. The gums, I see that his gums, it's pink, moist, no bleeding, no ulceration, no swelling. And then for the teeth, his teeth is aligned, good hygiene. He is wearing braces. The roof of the mouth, open for me. I see that there is no ulcerations, no lesions, no petechiae noted. No ulcerations, and it's pink and moist. And then I need you to stick out your tongue for me. Okay. Pink and moist, there's no fissures, no white patches, no ulcerations. And then I'm gonna have you open wide. And I'm gonna look at your tonsils for me. Take out your tongue. Softly here in your tongue so I can see your tonsils. Open wide. Okay, good. Perfect. Tonsils are 2+. With it fills up the 50% of the space, which is expected. Now I'm going to be inspecting for oropharynx and describe the Malampati airway classification. This class is graded from 1 to 4. 1 means full soft palate, and uvula and pillars are completely visible. 4 means only hard palate is visible. This is an estimate for amount of space available for intubation, and whatever patient is at risk for obstructive sleep apnea. I'm gonna have you open your mouth again, wide, and say ah.
Ah.
Okay. One more.
Ah.
Okay, perfect. The whole uvula, soft palate is visible. It's about grade 2. Oropharynx is pink, moist, and free of lesions. There's no ulcerations. And then now I'm going to be checking for your neck. Let me just put this in the trash. So I'm gonna be checking for your neck. The neck is symmetric. Neck is symmetric. It's midline. No swelling, masses, or discoloration. There is no JVD noted. So first I'm going to place one finger on the external notch and then 2 fingers to trace the trachea up. So, and then trace the trachea up. Trachea is midline with no deviation. Now I'm going to be checking for your thyroid. I'm going to have you face the other way from me. All the way back. There we go. Okay. Okay. So I am right behind him. I'm going to place fingers on the other side of the thyroid. And I'm going to have you swallow for me. Okay, perfect. There's no masses or nodules palpated. I'm going to have you turn your head slightly right and then downward a little bit. I'm going to displace the thyroid on the right side by using my left hand, pushing it towards the right. Okay, while I'm palpating on the right side, no masses or nodules are palpable. Now I'm gonna have you turn to the left and then downward a little bit. And I'm going to displace the thyroid on the left side. And I'm going to feel on the left, no masses or nodules are palpable. Okay, so now you're going to face this way for me. Okay, so now I'm going to be checking for lymph nodes. So the first lymph node is the preauricular, which is the front of the ear. Post-auricular, tell me if you are feeling any pain or tenderness, okay?
Okay.
Preauricular, okay, come forward a little bit, I can't reach you. Preauricular, post-auricular, occipital, tonsillar, submandibular, submental, and then we have the anterior superficial cervical, deep cervical, supraclavicular and infraclavicular. All lymph nodes are less than 1 centimeters in size. There's no, they are soft and they are mobile. If they are more than 2 centimeters inside, then that means there's some type of infection going on, and if they are immobile as well. Abnormal lymph nodes would be enlarged. They can be hard, fixed, and tender. Did you feel any pain at all?
No.
Okay, perfect. Okay, now I'm going to be checking for the neurologic test. First, I will have to check your balance and coordination. I'm going to have you stand towards the camera, and then you're going to walk that way and then back. Okay, so let me adjust the camera so the camera could see you. Okay, I'm going to have you walk for me and then back. Okay, perfect. His gait is smooth. Have a seat, like right in front of me again. His gait is smooth, steady, natural arm swing. There's no steppage gait. Now I'm going to be using the Romberg test, so I'm going to have you stand up. So this way, I'm gonna have you stand up for 1 minute. So 1 minute would be a little too long for this video, but I would have him stand up for 1 minute and then close his eyes. And then I am assessing for any sways or falling, or if he stumbles, that would be a negative Romberg test. But right now he is straight. There's no swaying or anything like that. So this is a negative Romberg test. It's assessing for your balance. Okay, now you can sit down. Okay, the next one I'm going to be assessing is the point-to-point test. So first you're going to touch the thumb with all of your fingers, just like this, and you're gonna do it as fast as you can. Perfect. Okay. And then movements are smooth and accurate. Now I'm gonna have you touch your nose, and then you're going to touch my fingers, okay? Touch your nose, touch my finger. Touch your nose, touch my finger, touch your nose, my finger, your nose, your finger. And then the other one as well. Nose, finger. Okay, perfect. So movements are smooth, accurate, there's no tremors or fasciculations noted. Now I'm gonna have you do the heel to shin, which is you're going to run your, oops. Sorry, the dog has been crying. Okay, now you are going to run your heel to your shin. Like this.
Oh.
Up and down, up and down. Another one. Okay, perfect. So that one's good. Put that back. Good movement. It's smooth and it is accurate. The next one is the pronator drift. So I'm gonna have you hold your arms up for me with your palms up. Hold it for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then you're going to close your eyes and you're gonna keep on holding it up for me for another 10 seconds. So this one is assessing for pronator drift. If it is to drift, then the pronator drift test is positive. So for this test, there's no pronator drift noted. Okay, you can open your eyes. The next one is the sensory function. So now it's the same thing like what we did a while ago with the Q-tips. You are going to tell me if it is sharp or dull.
Okay.
Okay? Let me get my Q-tip over here. Okay, I'm gonna need you to close your eyes. Oh, I wouldn't be able to access here. Okay, I'm gonna need you to close your eyes. Close your eyes. And you're going to tell me if it's sharp or dull, okay?
Okay. Dull. Sharp. Sharp. Dull.
Okay. And then I'm gonna go down again. This way.
Sharp. Dull. Dull. Sharp. Dull. Dull.
Okay, but this time I'm gonna have you actually point it for me, okay?
Okay.
While you're closing your eyes, now you're going to point where I'm touching it, okay? Okay, close your eyes for me.
Sharp.
You gotta touch it.
Oh.
Okay, close your eyes, okay?
Dull. Sharp. Dull. Sharp. Dull.
Okay, perfect. And then we're gonna do it again on the arms. Close your eyes, and you're gonna point, okay?
Dull. Dull. Sharp. Sharp.
Okay, perfect. So sensation is intact on both sharp and dull. Next one, what I'm going to do is the stereognosis test. So for this one, I'm gonna have you close your eyes. I'm going to put something on your hand, and you are going to tell me what it is, okay?
Okay.
Okay. Close your eyes. Okay, tell me what it is.
A paper clip.
Okay, perfect. And then on the other one too.
A coin.
Okay, perfect. You can open your eyes now. So the stereognosis is intact. And then again, I'm going to have you close your eyes again. I'm going to draw something on your hand, and you are going to tell me what it is, okay?
Okay. An infinity sign.
Number 8.
Oh.
Our infinity sign is good too. And then this one is
L.
okay, perfect. So graphesthesia is intact, and then the next one that I'm going to be checking is discriminative sensation. No, actually, that's it for the neurologic. Your discriminative sensation is intact bilaterally via stereognosis and graphesthesia. Okay, so for the meningeal signs, we're gonna do it while laying down. Okay, so move your head this way. There you go. This is the continuation of the assessment. This is Dennis Ventilla. He is my husband. Do you consent for this video to be recorded?
Yes.
Are you over 18 of age?
Yes.
Okay, perfect. So we are going to continue on with the thoracic posterior chest. So let me just make sure we could see the whole back. Okay. Okay. Stuff out of the way. Okay. So first I am going to inspect Dennis's back, posterior thorax. It looks like everything here is symmetric in size and shape. There are no lesions, there's no scars, there's no nevi masses or are visible. There's a little bit of discoloration here. Does this hurt when I palpate it?
No.
Okay. His skin is pink, it's smooth, dry. It's appropriate for his ethnic background, which is Asian. Spinous process is straight and scapula are symmetric. There's no unusual curvature noted, no structural abnormalities are visible. AP diameter ratio is 1:2. Patient is sitting upright, relaxed, and comfortable. Now I'm going to palpate. You are going to tell me if you are having any tenderness or pain, okay? So this way, I'm going to palpate in, out. Any pain at all?
No.
Okay, perfect. So there's no pain or tenderness noted. There's no masses, no thrills or heaves noted. Next one, I am going to check for respiratory expansion by doing. To do that, I am going to first find the T10, which is the inferior aspect of the scapular wing, and that would be over here. So I'm going to go straight over here, move forward in the wing, move over to the middle, and then down 2. So this will be the T10 over here. So I'm going to place my thumb. This way. There we go. I am going to place my thumb in the middle and then kind of push in a little bit, and I'm going to have him breathe. Inhale for me and exhale. Okay, so as you can see, that one is nice and symmetric. It's symmetrical breathing. The next one that I'm going to do is the tactile fremitus. So I'm gonna have you say 9. So every time you feel my palm on your back, you will say 99.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay, perfect. So vibrations are clear, they are strong and symmetric. There's no dullness or fluid noted. Now I am going to do the percussion. So what I'm looking for is a hollow, clear low pitch lung sound. If I hear any dullness, that would be like a consolidation. Any hyperresonance is an increased airfield area, which would be consistent with emphysema and COPD as well. Flat sound. If I hear flat sound, that would mean that I am over the bone. So I am going to start here. Okay. Um, uh, all lung sounds are resonant. So how I did that is I used my third finger, and that's where I percuss. And he is obviously leaning forward. Now I am going to assess for costovertebral angle if it's painful. So that is located on the 12th rib, which is down over here, a little lower. Um, First, I am going to create this triangular spot. So from here, up and then down and then this way. So that means I am going to percuss over here. Any pain at all?
No.
Okay, perfect. There's no pain or tenderness noted. The next one, I am going to be doing an auscultation. Bronchovesicular lung sound are heard in mid-scapular area. Vesicular lung sound are heard in the periphery. Any adventitious sound, including wheezing, rhonchi, rales. It could have underlying pathologies like, asthma, COPD, or even pneumonia. First, I am going to clean my stethoscope. And I'm gonna have you sit a little upright more for me, and then lean forward a little bit. Take a deep breath in every time you feel the stethoscope on your back, okay? If you feel dizzy, you just let me know and we will stop, okay? Okay, perfect. Okay, the next one that I'm going to be doing is the egophony. I am going to listen to your lungs again, but every time you feel the stethoscope touching you, you're going to tell me E, E, okay? And same thing again, if you feel like you're getting dizzy, you let me know and we will stop, okay?
E, 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 E.
Okay, perfect. I only heard the muffled E sound. There's no change to A and no evidence of fluid consolidation. So, uh, posterior thorax or posterior chest, lungs are clear at auscultation bilaterally. Okay, now you're going to face this way. Okay, perfect. So I am going to do an inspection. He is just anterior chest wall has a symmetric size and shape. AP diameter is less than the transverse diameter. Shoulders are symmetric. No lesions, no scars, no discoloration, nevi or masses are visible. No structural abnormalities. Skin is soft, dry. It is again appropriate to ethnic background, which is Asian. Now I am going to be assessing for respiratory rate and rhythm. He is not in any apparent distress. There is no cyanosis. There's no pallor. He is breathing quietly, rhythmic. It's unlabored, and there's no use of any accessory muscles. Now I am going to palpate for any tenderness and masses. If you feel any pain at all, you let me know, okay? Any pain?
No.
Okay, perfect. No tenderness or masses palpated. Now I am going to auscultate and listen to the respiratory sound again. So if I hear any bronchi or wheezes, those are adventitious sound. It could be COPD, again, emphysema, asthma, or even pneumonia. Bronchial breath sounds are located on the upper part of the respiratory tree over the trachea area, and anterior only. And then broncho-vesicular breath sounds are heard over the bronchi, and vesicular breath sounds are heard over the peripheral lung tissue. Okay, so breaths for me. Okay, perfect. Lungs are clear to auscultation bilaterally anteriorly. So now we are going to do the cardiovascular and peripheral vascular system. So the first one is aortic. The first one is aortic. Aortic is located on the second right intercostal along the sternal border. This is called the base of the heart. S2 is heard the best here. And then right across from it is pulmonic. Pulmonic is located on the second left intercostal space along the sternal border. Split 2 is heard the best at this spot. And then this is only the sound that you may hear normally vary with inspiration. Then right below it is Erb's point. Erb's point is located on the third left intercostal space along the sternal border. Next one is tricuspid. Tricuspid is located on the fourth left intercostal space along the sternal border. Split 1 is heard here the best. And then the last one is the mitral. Mitral is on the fifth, which is down here. Mitral is on the fifth intercostal space, midclavicular line. This is called the apex of the heart, as one is heard the best here. In the lateral decubitus position, you may hear S3 and S4 and the mitral valve prolapse. You can hear it here best. And then lastly is the epigastric area, which is just right below the xiphoid process and then left midline. So it would be right over here. This is where you may feel pulsation if there's any heart hypertrophy. And then also mitral regurgitation murmur and aortic stenosis is heard best during systole. Next, I will differentiate the squat test versus the Valsalva maneuver. So for the squat test, I'm going to listen to the mitral area with the patient standing. I'm going to have the patient go in a squat position. If I hear the click resolve, it could be from mitral valve prolapse. If I hear the click increases, then it may be from opening snap of aortic stenosis. And then for Valsalva maneuver, I'm going to have the patient lay down in a supine position. And then again, I'm going to listen into the mitral area. And then I'm going to have the patient bear down as if he is having a bowel movement. And if the click increases when the patient is bearing down, then it could be from mitral valve prolapse. But if it resolves or decreases, then it may be from aortic stenosis. So now I am going to inspect the pericardia. I'm going to have the patient lay in supine position. Okay, so now I am going to be listening on all 5 precordial areas with the diagram of my stethoscope. Okay, and then now I am going to be listening to all 5 areas with the bell of my stethoscope while the patient is laying down. And mitral. Perfect. There is a regular rate and rhythm, S1, S2. There is no S3 or S4. I did not hear any murmurs, no rubs or gallops. And then next I am going to listen to the arteries. I am going to assess for any bruits, and I am going to use the bell of my stethoscope. So I'm going to have you inhale for me, and then you're going to hold your exhale, okay? So take a deep breath, and I'm going to listen right here. And exhale for me. Take a deep breath. Listen again. And exhale for me. I did not hear any bruit sound. Now I'm going to listen to the abdominal aorta to check for any bruit. And this is located in between xiphoid process and the umbilicus in the midline. So xiphoid process and the umbilicus. I'll listen over here. And I did not hear any bruit. On the next one, I am going to listen to the renal arteries with the bell of my stethoscope. Uh, that is located below the abdominal aorta and lateral midline bilaterally. So just over here and this way as well. And I did not hear any bruit as well. The next one I'm going to be listening to is the iliac arteries with the bell of my stethoscope. It is located below the umbilicus on the lateral midline bilaterally. So it will be over here and this way. And I did not hear any bruit as well. The next one I'm going to be listening to is the femoral arteries with the bell of my stethoscope, and this is located on the superior iliac spine and the pubic symphysis within the groin region and bilaterally. So that would be femoral will be over here and this way as well. Okay, now I will be assessing for the pulses while the patient remains in supine position. So the pulses are graded on a scale of 0 to 3 plus. 0 is no pulse or absent, 1 plus is a weak pulse, and then 2 plus is brisk, which is all as expected and normal, and then 3 plus is bounding. So the first one is the radial pulse. I am going to feel it for about 60 seconds or 1 minute. So this is the radial pulse over here. So for the purpose of this video, that has already been 60 seconds. His pulses bilaterally on the radial is 2 plus. And then I'm going to feel for the femoral pulses. It's located halfway between the superior iliac spine and pubic symphysis bilaterally, so just right below the inguinal ligament, so just right over here. And I can't feel it for one hand, so most of the time we have to use 2 hands and then push a little deeper, so that would be over here. So for the purpose of this video, this is about a minute now, and the pulses is 2 pulse. Then I'm going to do it on the other side as well. And this is about a minute now, and the pulse is about 2 plus. So the next one that I'm going to be assessing for is the popliteal pulse. I'm going to have him bend his knee, and I'm going to put my fingers under his knee, and then my thumb on top of his knee to feel for the popliteal. Okay, so this is about a minute now. His pulse is 2 plus. Then we will do it on the other side as well. And this is about a minute now, and his pulse is 2 plus. And then the next one that I am going to be assessing is the posterior tibialis. So let's see here. Okay, posterior tibialis is posterior tibialis is right by the ankle. I'm gonna have you bend your knees, both of them, and then I am going to feel for the pulses this way. And for the sake of this video, this has been about a minute, and his pulses are 2 plus. So the pulses are located in the medial malleolus bilaterally. The next one that I'm going to be assessing is the dorsalis pedis. It's located on the lateral extensor tendon on the great toe, and that would be right over here. And that's been about a minute now, and his pulses are 2+ bilaterally. Okay, so now I am going to be checking for edema. Edema is the swelling of the arms and the arms or the legs. It's a soft palpable swelling when pushed with thumb. There should be a depression after 1 to 2 seconds, and it's graded on a scale of 4+. Dependent edema is a form of peeling edema, but it occurs in lower extremities, so it's on the legs. It's due to prolonged standing or sitting. And then anasarca edema is on upper extremities. Generalized edema usually due to liver and kidney failure. So for this one, there is no edema. And then we're also going to check the lower extremity. Over here, there's no edema, and over here as well, there is no edema. Okay, his skin temperature is warm, upper and lower extremities, which is expected. Now I'm gonna have him sit up, and we're gonna check for his skin turgor. Okay, so the skin turgor is usually checked on this area over here, so we're going to pinch it. If it stays tented, then that means there is a tenting, and then for him, there's the skin is non-tenting. We usually check it directly below the collarbone, and then we're going to check for the capillary refill. We're just going to pinch the nail beds over here. Okay, and it's brisk, less than 3 seconds. And then we're gonna do the same with his toe as well. Perfect. So his capillary refill in upper and lower extremities are less than 3 seconds with smooth nail beds. Now we're going to move to abdominal assessment. Okay, move your legs a little bit. Okay, we're going to continue on with the abdomen assessment. So first, I am going to inspect the abdomen. I see that it is slightly protuberant. It is symmetric. It's free of any lesions, scars. There's no nevi, masses, or any striae. I don't see any pulsations or even dilated veins. If there is pulsation visible, it could be a passable abdominal aortic aneurysm, and I would not be palpating on that area. The next one is I am going to auscultate on all 4 areas for about 1 to 5 minutes, beginning with my right lower quadrant. So for the purpose of this video, we will say that I have listened about a minute for every quadrant. Right lower quadrant is normal active. Right upper quadrant is normal active. Left upper quadrant is also normal active. And left lower quadrant is normal active. And now I am going to be listening over the spleen, which is on the left upper quadrant over here. I did not hear any friction rub. And then I'm also going to be listening on the liver on the right side. And I also didn't hear any friction rub as well. Friction rub is a grating sound that may vary with respiration. It indicates the presence of any inflammation on peritoneal surface. Um, it's possible that there could be a liver tumor, it could be from chlamydia, gonorrhea, and any other GI infections. It could also be from a liver biopsy or any splenic infarct. The next one that I'm going to be doing is uh, I'm listening for the venous hum, which is a soft systolic and diastolic hum that may be heard over the liver, epigastric, and the umbilical region, which is negative for him. For if I hear the venous hum, any increased in collateral circulation, it is sometimes prominent with hepatic cirrhosis. The next one is the percuss. So I will be using the reflex hammer and the third digit of my finger. And then I'm going to start on the right lower quadrant. I am looking for a tympanic sound um, throughout the abdomen. Okay, perfect. Um, I am also I am also going to check for the hepatomegaly. So to do that, I am going to start in the third intercostal space and then downward, and then also I'm going to start in the after that I'm going to stop when I start hearing the dullness, and then on the bottom over here I will start in the umbilicus area in the midclavicular line, and so I'm going to start moving up. It's a timpani sound until I hear the dullness, and then I have to measure. It should be 6 to 12 centimeters. So I'm going to start that. Oh, there it is. And there it is. So I'm on this area right here, and we are going to measure it. And that is about 7 centimeters. 7 centimeters for this patient. Now I am going to do light palpation and deep palpation on all 4 quadrants as well. And you are going to let me know if you feel any tenderness or pain, okay? Any pain at all?
No.
Okay, you're going to relax a little bit, okay? Relax for me. It's a little bit deeper over here. You feel any pain at all?
No.
Okay. So the patient did not feel any pain or any tenderness. I did not palpate any masses. Now I am going to check for hepatomegaly or splenomegaly. So from the right, I am going to hook my hand from his back and then lift it up so there is no hepatomegaly. And then from the left side, I am going to hook my arm. Well, obviously in the real world, I am going to be on the other side of the bed, and then my arm across from him, and then I will hook my arm from behind him and then lift up to check for splenomegaly, and there is no splenomegaly. The next test that I'm going to be doing is the test for appendicitis. So these are 4 tests that could if he tests positive, then it would be a positive for appendicitis. So the first one is the psoas sign. So I'm gonna have him maybe move this one a little bit more. Okay. So I'm gonna have him put his arm on his thigh over here, and I am going to lift up his leg against resistance. Okay, so you're going to raise your thigh against resistance. So raise your thigh for me. Do you feel any pain at all?
No.
So if the patient is feeling pain, especially on the right lower quadrant, then that would be a positive psoas sign for appendicitis. The next one is called the obturator sign, with the knee bent inward. I'm going to inward. I'm gonna put it this way. If the patient complains of any pain, that could be a sign of appendicitis as well, because it's putting pressure on the right lower quadrant. So this way. Okay. And then the next one is the rebound tenderness. So if patient feels sharp discomfort with the pressure from palpation on the left lower quadrant, so I'm going to push down here and then release. So if he feels pain on the right lower quadrant, that would be a positive rebound tenderness. And then the last one is the Rosving sign, which is I will press deeply on the left lower quadrant, then quickly release it. Same one. And then again, if he feels pain on the right lower quadrant over here, then that would be a positive sign for appendicitis as well. And then the last one that I'm going to be checking for is the test for cholecystitis, which is the Murphy signs. I'm going to press my fingers to the right rib cage over here, and you're going to tell me if you have any pain, okay? So I'm going to press down on that right upper quadrant over here, and he didn't feel any pain, so that is a negative Murphy sign. But if he is to feel pain, deep inspiration, that means it's a positive Murphy sign or inflamed gallbladder. So we're gonna do it again, and I'm gonna need you to take a deep breath. Do you feel any pain at all?
No.
Okay, perfect. And the last thing that I am going to do is to complete the neurologic part of the assessment. So for that, I am going to be doing the meningeal seal. So while the patient is laying flat, I am going to be assessing for the Brudzinski test. So to do that, I will remove the pillow, and I'm going to be extending your neck towards your chest, and I'm going to be looking for any bending of the knee or the leg, and that's a negative Brudzinski sign. There is no flexion of knees or hips. The next one is the another meningeal sign as well. I'm gonna have you relax your legs and this way maybe. Okay, I'm gonna pull on your leg and bend it, and then up. Any pain on your lower back?
No.
Okay, and the other one as well. Pain on your lower back?
No.
Okay, perfect. So that one would be it's a negative Koenig's test because he didn't feel any pain while I was flexing and extending his leg. And that concludes my head to toe assessment. I thank you for your participation, Dennis.